My name is Bill Dempster with C360 Public Affairs, but as often as not, I'm with Durhan Wong Rieger and Angela and the team of CORD Canada, the Canadian Organization for Rare Disorders, and it's just such an important day for everyone. It's International Rare Disease Day. I even pulled out an old square or a rectangular pin to mark it, and I'm hoping that everyone on the line and beyond has found a way to stand up for rare diseases, and I know you are because you're all here. Um, just a reminder, if you're not on the panel, just kindly put your microphone on mute and your camera as well. We may call you back up. Thanks very much. And I know Angela is going to be able to either mute you or turn your camera off as well if and as needed. So this is a really special year. It's 2025, which means it's been 10 years exactly since CORD launched Canada's National Strategy for Rare Diseases. Many people on the webinar were part of bringing that plan together. It was a huge effort. We hosted events across the country in major cities. We even got kicked out of the Fairmont Hotel Vancouver when the health ministers were meeting. And then there was such a media blowback that we got invited back in. And to be honest, CORD has never left since then. It's been on the health ministers' agendas since 2015, and there's been so much that's happened since then. I want to also acknowledge some of the champions who helped lead on those events who aren't with us today. And for example, many of us remember Jonathan Pitre here in Ottawa. He was known as the Butterfly Boy. He was such an inspiration for us, and I know many of you on the line as well, along with all of the others who aren't with us who helped us, get to where we are today. So since 2015, we had a big bucket of money promised in budget night 2019 at the federal level. We had committed federal funds in early 2023, and now we have a lot of those finances starting to flow. So for today's Rare Disease Day, we've got an incredible group of Canadian and global experts to share with us how they're playing a role in helping deliver maximum value to patients and provinces with that $1.5 billion over 3 years through the National Strategy for Drugs for Rare Diseases. And just for a quick review of how that funding is working in practice, the provinces can access up to $1.4 billion of that money through bilateral agreements. Now, they need to fund at least one medicine on a common list, which has been negotiated through the Pan-Canadian Pharmaceutical Alliance. There's already a high-value deal that's been done, maybe rebates from the manufacturer to governments. But really, all Canadian public payers, federal and provincial, have committed to fund or at least have an intention to fund all the medicines that go through the PCPA. So we've got a lot of money to put to work for Canadians, and that's where the consistency should come in. There's also money for screening and diagnostics, as well as research and health system coordination. And this week we've had additional news. First, Manitoba signed its bilateral deal with Ottawa yesterday, which is terrific. And we've picked up that Quebec has a formal negotiation mandate to engage with Ottawa and get a deal done. And maybe that province will come through tomorrow. And that would leave only PEI and Nova Scotia to sign their deals. And that would give them access to hundreds of millions of dollars, some of the big provinces, and big chunks of change for smaller provinces too, that would even be dated back to April of last year to get that money out. And it's super important because we're watching the provincial budgets, and almost all of them are in deficits. Even Alberta's budget this week announced that province will be in the red for this year and the coming years, actually. So this is so important because for provinces like Quebec and others that are looking at restricting super important exceptional access programs like Patient d'Exception, we're very hopeful that this additional money will help save some of the ways that a lot of the patients on the line are able to get access and maybe expand it. And one challenge, and this we'll put out to CORD and to everyone, is how can we make sure that this funding is additive? It's not just going to general budget coffers so they can cut back on other services. This has to be something that actually gets to patients, and that's where this panel comes in. I'm going to quickly introduce the panel in terms of the order of operations. Each of them are going to have 6 or 7 minutes. A few of them will have slides. I challenge each of you to keep it really tight. we're going to pass it over first to the president and CEO of CORD, who doesn't need any introduction, Durhan Wong Rieger, who will explain the why of today's event and how CORD's vision for better care for rare is coming together, and where it's not, where Durhan, you're going to make sure it does. Durhan will be followed by the Children's Hospital of Eastern Ontario, CHEO's Dr. Kim Boycott, who will share how the Think Rare program uses artificial intelligence to identify undiagnosed children and youth so that we can end that diagnostic odyssey that we so regularly talk about. Then virtually, we're going to fly out to British Columbia, where we're going to talk funding, finding, treating, and tracking with BC Cancer's Von Hippel-Lindau Clinics, Dr. Mariam Soleimani. Dr. Soleimani will review why it's important to take a more comprehensive approach to rare. We're going to stay in BC and be joined by Dr. Tom McLaughlin at BC Children's and his program's unique approach to tackling complex cases. Back here in Ontario, where I am, we're honored to be joined by some of the most determined patient advocates that I've ever had the chance to work with and know. And that's Susie Vanderwick and Jeremy Bray of Cure SMA Canada. And there are some bureaucratic hurdles for making sure that adults with SMA get the treatments that they need to continue to access care. And finally, we're going to head further, well, not further, but back out west, where Dr. Deborah Marshall at the University of Calgary is helping develop a protocol and implement a survey on the impact of rare diseases on patients and health systems. And Deb, I'm hoping you're going to put a plug for everyone on the line to be ready to respond. Get those keyboards out, because your experience is so needed for that research that we're working on. The last plug I'll say is, speaking of Calgary, CORD is going to be hosting its Rare Disease Day Calgary event in Calgary, April 29th and 30th out there. And maybe Durhan, you're going to put a bit more of a plug in for that, because I'm going to hand it over to you to explain the why of today's panel. And then, so yeah, everyone who's not speaking, just we're gonna go off video. I may ping you if things are getting a little bit long. Try to stay on time. Over to you, Durhan. Explain why we're here.
Okay, thank you very much. I won't repeat what Bill has already said. I think it's been so important. The why, actually, I think Bill talked about with $1.5 billion. I think people are a little bit surprised sometimes as to how, when we have been given $1.5 billion for a rare disease drug strategy, we can still be complaining. And it's not that we're complaining. We are thrilled to have the funding. We just want to make sure the funding really is, as Bill says, additive. And there's nothing that forces it to be additive. And that's the challenge. I'm actually speaking to you from Edmonton, where I'm going to be at a panel with the University of Alberta today on rare diseases. I spoke yesterday at a panel with the Mayo Clinic in the US. I'm actually going to be speaking tonight on a panel with Hong Kong. So truly, we see Rare Disease Days as a global initiative. And I think we're all recognizing that the ability to actually advance rare diseases goes far beyond drugs. Drugs is obviously important, but we need to look at the rest of the system. And I think you'll see each one of the speakers here today talks about what we had pleaded for when we asked for the funding for rare disease, not just a drug strategy, but a strategy that we have to fund the entire journey, right? From diagnosis. We have to make sure that patients are getting into the kind of specialty clinics and getting the integrated care that they need. And that's, so Kim's going to lead on that. Tom's going to talk a bit about, where the vision is for rare and complex children. We need to make sure, though, that people get access to treatment. And I think they need to be accessed in a way that's tracked. And Dr. Solomon is going to help us understand kind of what she's doing, to actually diagnose, bring in the patients, and then track them as they're on care. And then we're going to have, Jeremy and Susie who are going to really talk with us about, it's actually Jeremy's in Manitoba, Susie's in BC. So all of these represent key components of what we have been proposing as needs to happen with that money. We recognize, and then we're going to end up with Deborah, really kind of bringing it to us in terms of how we need to be accountable for it, but demonstrate as well. Just because we don't treat rare diseases does not mean they're not costing patients and the system, and we need to be able to capture those costs. So for us, we're realizing that with the monies, the provinces signing on, they're going to get the monies. What we realize is that just doing that is not going to fulfill the commitment. It's not going to assure that we have the diagnosis. It's not going to assure that we have specialty care. It's not going to assure that we're going to be tracking them. So we're back to saying it's back to where we started from. It's up to us. And we're going to have to do it as a community. And lucky for us, we have an amazing rare disease community, not only committed, not only dedicated, but full of the expertise. And I think Kim and others and Deborah and us will know. Everywhere we go around the world, people are talking about, the experts that we have in Canada and what we can bring into forming the system that we want. So what we're saying to the provinces, okay, you've got money. You need to make sure it goes to rare, and we're going to help you identify how that money should be invested to make sure that it does get to the patients in a way that's going to be the most cost effective. For us, this makes sense in terms of care. So I'm going to pass it over to Kim, and I'm going to come back at the very end, hopefully, before we do questions, with a couple of cases that we also recognize are not being addressed. So thanks a whole lot to everybody, and Kim, over to you.
All right. Oops. Let's make sure we can see this again. Okay, excellent. I'll just take 5 minutes and give you a quick highlight on our approach to using AI to shorten the diagnostic odyssey for children in our institution. And so, let's go. Oh, here we go. Okay, so this is our background. And so what we were trying to do is think about ways that we could help identify individuals with suspected rare genetic disease earlier in their diagnostic journey, where they might be going unrecognized by frontline providers for all the reasons we know that can happen when we're dealing with rare conditions. And we wanted to leverage some of these new electronic medical records that dump very structured data into data warehouses. And at my institution at CHEO, we've had the EPIC electronic health record now for actually almost 10 years in genetics. And so we had an opportunity where we could start to leverage this structured type of data. And so what's happening every day in this environment is that all of the data for the kids who are seen at our institution are extracted from the electronic health record, transformed and then loaded into a warehouse that can then be used and searched with different algorithms that one can develop. And so we wondered a few years ago whether or not it would be possible to search the warehouse to find patients who maybe have an unrecognized rare genetic disease as sort of a proof of concept that maybe one could do this. And so we developed what we call the Think Rare search algorithm. And this happened during the pandemic, so it probably took a little longer than we had hoped. But what we were trying to do is equip frontline providers with tools for diagnosis and referral. And we based it on a rule-based expert system. And we started off with several phases of this project. And so they're listed there on the right. So phase 1, 2, and 3, we're currently in phase 3. Phase one was a retrospective proof of concept study, going back and looking at all the records from 21 to 2024. And just so you get an idea of the scope of that, that is 300,000 different patient records over that time period. Phase 2 was this silent prospective trial where we had it operating in real time, but it was not alerting other providers in the system because we needed to sort of practice it out. And phase 3 starts on March the 6th. Timed for Rare Disease Day, where the clinical best practice advisory will now notify in real time when a patient is flagged by the Think Rare search algorithm. And so just to let you know, this has taken a long time, 5 iterations that were further improved for sensitivity and specificity. As you can see there, over 1,000 hours of time to make sure that we're identifying the right patients. And basically how it works in the most simplistic terms is that it has a set of exclusion criteria and a set of exclusion criteria. And it's really searching for children seen at this institution who are not seen exclusively in a few departments that would have other causes for having a reason for the complex flag. We don't want to see those kids that have already seen us or already have abnormal genetic test result. And there are diagnostic codes on our exclusion list that are just too common in the general population. And so once these exclusion criteria have worked, we then use inclusion criteria to look at things like congenital anomalies, developmental delay, intellectual disability, seizures, hypotonia, that sort of thing, with encounters where they've seen 2 or more departments that are highly enriched for rare disease patients. And it's the intersection between those 2 things that we flag. Keep in mind that we have a strong genetics department here at the Children's Hospital in Ottawa. And as a result, we don't expect that there are many patients out there that have not come to see us, but we did find some. So the outcomes of phase 1 and 2 is that we had 23 patients referred. They were all seen within a few weeks in our rapid genomics clinic. And there is an absolutely outstanding diagnostic yield of 70%. Now, when we take all comers into a genomics clinic, like the rapid genomics clinic that we have, we would expect a 30% yield. And we have a 70% diagnostic yield, meaning that there are patients in our system that have been on a diagnostic journey and have not been flagged. And you can see 2 of our little guys there, as well as a very nicely documented diagnostic journey of a patient that we flagged who was 17 years old that had never been to see us. So our best practice advisory goes live next week, which will pop up and says this patient has been flagged by ThinkRare and gives the frontline providers what to do in terms of making an automatic referral and being flagged as a ThinkRare patient so we can see them quickly because they've already been on their diagnostic journey for a while. And then we're going to look at the outcomes of this over the next 2 years. And the final thing we want to do is plans for expansion. So we're Alberta Health Services is keen to bring this in, as well as SickKids. Institutions without Epic are interested, as well as we've had a lot of interest from international groups who are very keen to make sure that this kind of thing is running in the background of their system. So as these electronic health records move in, there'll be a great way for us to hopefully be able to see them much, much earlier in their journey than when they're 17 and about to leave our institution. So thanks, that's my little bit.
Kim, that was fantastic. Thanks so much. All right, well, let's head out to British Columbia and hear from Dr. Soleimani at BC Cancer.
Thank you so much. It's such a pleasure to be here. I wanted to use this as an opportunity to kind of share some of the work we've been doing in BC at our Von Hippel-Lindau Clinic. And I hope it inspires others on the call today to explore similar endeavors. These are my disclosures, none are relevant to this presentation. So just as a brief background, VHL disease is a rare hereditary cancer syndrome. In the literature, incidence is 1 in 36,000. But we believe it is underdiagnosed, and that is probably actually higher. It's inherited in an autosomal dominant pattern, meaning that if you have VHL disease, the likelihood that your offspring will have it is 50%. And patients with VHL require very multidisciplinary care from infancy to death. VHL results in the development of tumors in various areas of the body. And this is often diagnosed in infancy in those with a family history, but can also present as a first case in a family in early adulthood as well. As you can imagine, with the growth of tumors in different areas of the bodies, you need lots of different specialists involved in the care of patients. And historically, the way that we've managed VHL disease is by surgery to remove these lesions over and over and over again, which can be obviously very taxing for patients and it can affect their organ function. In 2022, belzutifan became the first drug available for treatment of VHL disease, and it's truly been transformative in how we manage VHL disease, and now means that those decisions are not as straightforward about going to surgery. They're much more nuanced. New expertise and new knowledge is required to make sure that we're giving patients the best care that we can. The challenge is, like many other rare diseases, the care of patients with VHL disease has been historically very fragmented. So for instance, a patient with a history of brain lesions may be followed by a neurosurgeon, but their kidney lesions or their pancreatic tumors may not be monitored closely. And now it's even more multifaceted, as I mentioned, because now we have to decide between surgery, treatment, or monitoring. And so in 2022, I met a patient with VHL disease who shared with me that he had been going down to the NIH to have surveillance. Surveillance is a critically important part of how we look after VHL disease so we can be proactive in managing it. And I was perplexed by why this patient was going to the NIH. And he said, well, I go there, they have a clinic, they look after everything. And then I have peace of mind that all my surveillance is managed. And so I said, we should be doing this here in BC. Why would a patient from Northern BC have to go down to Washington, DC for this? And that's how the BC Cancer VHL Clinic started. And so our goal is to provide timely access to coordinated care, treatment, and support survivorship and advance knowledge and expertise. So we started in November of 2022, and we really are the first very comprehensive clinical care center in Canada, but I certainly hope we are not the only one. And since then, we now have about 76 patients who are being followed in this clinic. The clinic is sort of led by myself and our nurse navigator, Anna Pasco, and we sort of serve as the quarterbacks. But we don't have all of the knowledge that we need to look after these patients. And so one of the first things that I did when we started this clinic was reached out to other providers and said, listen, I want to start this program. We'll sort of serve as the home base for patients. We'll order all of their testing. We'll coordinate all their referrals. And if I think a patient might require input from a spine surgeon or a neurologist or urologist, would you be able to come on board for quick consultations to help expedite care? Had a great response for all of these folks who have been absolutely instrumental in the success of the program. And we're constantly expanding it. So now we've got maternal fetal medicine involved because these are often very young patients who have to deal with unique challenges in pregnancy. We have a pediatric oncology pathway. And so later today, I'll be going to BC Children's to chat with them about developing a similar clinical program that will allow us to ensure we have a smooth transition when patients phase out of pediatrics and go into the adult world. We know that's where care often falls apart. That's an area of need. So we want to make sure that they are efficiently transfer of care from the children's program to our program, and hopefully nothing gets lost along the way. We recognize the unique psychosocial challenges of living with a rare chronic disease. And so having our patient and family counseling and our psychiatrists on board is also something that we're working on to address those needs. We have three pillars essentially for how we provide care. One is, of course, the care delivery, and the goal being to coordinate and centralize care for VHL in British Columbia, to provide educational events for care providers and for patients with these new developments. We hope to develop guidelines for surveillance and management in this new era with medical treatment. And of course, as I mentioned, that transition of care into the adult world. We work with a variety of organizations to sort of collaborate and to put all of our resources in place together to expand our reach. And of course, research and innovation is absolutely critical. So we are looking at our own experience and following patients to see how they do, what are their outcomes. We have a prospective provincial database for patients with VHL now in BC. We just received about $1.2 million in funding to develop a biobank that will allow us to do some really interesting scientific research. And ultimately, what we really want to do is to bring more clinical trials and new opportunities for our patients. And we really do look after sort of the full plethora of needs of patients, but for the sake of time, I won't go through this. I do want to kind of outline the referral pathway, because this was something that we put a lot of effort into to make sure it's as efficient as possible. We have a pretty clear sort of pathway of how patients are referred. Our referral clerks have received training on how to triage in an expeditious way those referrals. When we receive that referral, we are alerted to it, and Anna does an intake form completion with patients to identify their areas of concern in their care. What is their most recent testing they've had done? They then have the consultation with me, and we then develop their care plan and follow up. So this is some outcomes data that we just presented last month at an international meeting in San Francisco, where we looked at how outcomes have changed since the development of this clinic. As I mentioned, there are guidelines for management of VHL disease, but guidelines are only helpful if they're being followed. And so we looked at rates of adherence to those guidelines prior to connection with our clinic and afterwards. And you can see a really dramatic improvement in adherence to guidelines. And that's absolutely critical so that we can be proactive in the care of these patients as opposed to reactive, where we know often that's where complications arise. Importantly, as you can see here, about half of our patients actually live more than 500 kilometers away from BC Cancer Vancouver. This is a clinical model that provides care for all patients in the province of BC. And you can see that about half of our consultations are done virtually. So we really have embraced telemedicine to be able to keep patients close to home, avoid unnecessary costs of travel, and still provide equitable access to care. As you can see here, we demonstrated that there was a significant change in the management plan of patients after they were seen in the clinic, but there was no difference in the time to consultation depending on how far you lived. So whether you lived 5 kilometers away from the clinic or 500 kilometers, the time to consultation was the same. So this is the beginning of something what I hope is exciting and more of a broad sort of national goal, and that is to develop a Canadian VHL clinical and research consortium to bring together providers from across the country to help create sort of a national network, which we know is so important in rare diseases. It will allow us to inspire our trainees to focus in areas of rare diseases and keep that talent in Canada. It allows us to have a base for advocacy so that provincial and federal money can go towards research and commitment and drug development in rare diseases. We're working on developing a quarterly national tumor board so that we can help make decisions in the care of patients across the country and give good quality care. Patient engagement is absolutely critical. We have patient advocates that engage with us to make sure that the work that we're doing is patient-centered. And there are lots of opportunities that will come about. So I want to thank you all so very much for the opportunity to present today. I'd love to collaborate with those of you who are interested in this area of work. What we have done is not anything particularly novel, but this is work that is not funded as of yet. Anna and I don't have protected time or resources for this. We kind of do it on the side of my regular oncology practice, but I think that shows that it's possible. And I hope that with showing some of these outcomes, we can then get some of the financial commitment from the Rare Disease Drug Strategy to build on this. Thanks very much.
That's terrific, Mariam. And I know that many people on the line are involved with the Canadian Rare Disease Network. So this seems like such a perfect case study for the how and the why of building that network. So if Francois, Leanne, Craig, Kim is involved too, I think you're gonna get a lot of emails after this this webinar. Tom, over to you to talk about complex care and what you're doing to help be comprehensive in our approach to this.
Thank you so much. I'll quickly get over to slideshow here. So it's nice to meet you guys. Are you seeing my main screen or my notes screen?
Your notes screen.
I think I need
It
to
says you
turn
have no
off my-
notes.
There we go.
Yeah.
Let me just quickly change that up. I'll get started in the meantime. I'm Tom McLaughlin, and I'm a hospitalist pediatrician at BC Children's Hospital. So in my day job, what I do is I take care of children who have the highest degree of healthcare needs in the province. So those who can't be managed as an outpatient or managed in a community hospital. And although children with rare diseases account individually for a small portion of the population. As we know, collectively, it's not small, and then healthcare needs are even larger. And so what drew me to this project was seeing all of the gaps in care for this population. And so what we are doing is we're building a new center for children with health complexity located off-site from our acute care hospital in these lands in the eastern part of Vancouver. I'll acknowledge these are unceded lands of the Musqueam, Squamish, and Tsleil-Waututh people. I'll go over the population, what our plan is for service design, and then a little bit about the building. And so the idea with this redevelopment project is for us to create a specific purpose-built facility that offers both on-site and virtual services for children with the highest degree of health complexity. Although there are some children who have acquired illnesses, a very sizable fraction of these children are those who have rare diseases, often genetic rare diseases. And so our target population in BC is about 2,000 to 2,500 children. These are defined as children who have the highest degree of health complexity needs. And so these are children who have generally multiple organ system involvement, who have significant functional limitations, often requiring mobility assistance like wheelchairs or lifts, have substantial healthcare needs that require a high degree of care coordination, and also have substantial social care needs. And I think that as many of you guys know, there's significant gaps in our existing system of care coordination. The previous presenter talked about, all of the gaps that happen for a particular population. The idea here is that we want to capture all patients who aren't in an existing multidisciplinary program. And this has resonated with our community throughout the design process. We've been co-designing with patients and families. These are just two of our patients and families. And one of these parents that is mentioned here is a trained architect, but had to give up her work in order to take care of her child. The other parent actually had to give her child into care because his care needs were so high. And she recollects that if there were a better system, she wouldn't have necessarily been able to do that. And so that drew her to this project. And that's what drew me to this project. I'm sure we all know there are gaps accessing medications, which is such a key issue for CORD. There are also gaps in care coordination, in training and education, in equitable access to services, in family wellness, sibling support, culturally safe care. All of these things are what this center is meant to address. One of the key components of this center is diagnosis agnostic care coordination. So, much like the previous presenter went over all the specialists involved in Von Hippel-Lindau, we know that so many patients like this have potentially dozens of physicians, allied health teams, ancillary services, social care supports, the school, the ministry. All of these other parts are the responsibility right now generally of families, or in some small cases of highly effective multidisciplinary clinics. And so we've developed a model with key workers who have longitudinal relationships with families. That includes nursing support, medical support, social work support, and logistics support, and will follow and advocate for families throughout the healthcare system. Another big part of our service model is training and education. Families often describe kind of falling off a cliff. They might have an initial diagnosis as an inpatient, and then they're sent home with a ventilator and a feeding tube and learning how to use a lift. Training and education for caregivers and for that whole expansive team. There are often siblings, cousins, grandparents, schools, daycare providers involved in care. And right now that burden often falls to caregivers themselves. And so we want to have this be really a core part of our program. And finally, we want to support families as well as patients. And so a big part of this service is access to mental health. We will have psychiatric and psychologic support for patients, caregivers, and siblings. Emotional well-being for all involved, social connection. Our space is meant to be empowering and to be a place where people can come together and experience joy, as well as financial and social support. Having A child with health complexity often requires at least one parent to give up work, apply for a variety of benefits, which I'm sure CORD members are well aware of. And we want this to be something where we can lend our expertise and advocacy throughout this process. And Canada's a big place. Yes, we're building a building in the city of Vancouver, but every part of it is designed to be virtually enabled as well. So there is in-person care, but every part of the care, except for the inpatient service, which I'll get to next, is also available virtually. And the building includes design for a lot of virtual enabled spaces. So teaching spaces, for example, have very high fidelity virtual supports. There is an inpatient-like unit, which we are calling the Child and Family Suites. This is meant to be a transitional space, often post an acute care hospitalization, where that care coordination work, that training and education work, and that family wellness and support work can happen in an intensive environment. But we're purposely designing it not to be at an acute care facility and not to be as unhospital-like as possible. And because this is an innovative program that's serving such a large population, we have a high degree of research work that is currently in progress. For example, one of our research projects right now is to develop a new administrative data system that looks at meaningful outcomes for this population at large. Right now, we capture a lot of health utilization data, emergency department stays, number of diseases, but what's not captured well is functioning. If we are able to have a child go to school as a result of our care program, that is a successful outcome that should be captured in administrative data. So we're working with world experts to develop an international classification of functioning system. And all of this is with patient partners embedded in our research program. And so we are building a building. As mentioned, there's a high degree of virtual care. I'll go through some of these slides. You can see it's meant to look as empowering for this population as possible. You can see the family feedback was actually that the mobility assisted ramp should be visible from the outside. And so you can see that in our main entrance here. This is the ramp. And so this is meant to be a space that people with varying abilities can use. And we use wood throughout the design. And so this is meant to be evocative of a cedar tree, which is local to Vancouver. All of our spaces are appropriate for people with mobility assistance, and desk heights and other things like that have been designed with this population in mind. You can see there's also places for gathering and joy, and all of these places are again designed with this population. And there's a significant outdoor space. This is next to a park. Oftentimes children's hospitalization experience is very institutional and very cold. And so we wanted this to be connected to nature as well. And this is the entrance to the inpatient space, the Child and Family Suites, which, as you can see, is purposely designed not to look like a hospital. This looks like townhouses. And the inside of the suites similarly are places for families to heal. So in our environmental review, there's only one other place in the world that we found that had this setup, where there is a child space that still has access to medical gases and technology and monitoring. And then you can see on the other side, there's a family space, which could fit an entire family if they had to come down from a remote location, and is purposely not a healthcare space. And this is meant to support the training and education and transition to home for families who similarly have divisions within their home. These are just some of the other spaces. And so really, I think, for this audience, what's really important is all of the things that surround care for children with rare diseases. Our goal for this center is to be the first of its kind purpose-built facility to build in that care coordination, training and education, family and wellness support for children throughout BC Yukon and their families. Thank you very much.
I can't believe that's going to be in Canada. So congratulations for seeing that vision through to break ground. And I know that Deb Marshall and the team at University of Calgary are taking note from the last two sessions about how many touch points patients have with the system across different different parts of the health system, and hopefully they can do it in an environment like that. We're going to pass it over to Susie Vanderwyk and Jeremy from Cure SMA now, to talk about how transitions aren't as wonderful necessarily as the ones that Jeremy and Mariam were describing, and what we can do about it. Susie, over to you.
Hey everyone, Susie Vanderwyk from Cure SMA Canada. We support patients affected by spinal muscular atrophy, which is a disease affecting the nerve cells of the body, creating a result of generalized weakness, and it's progressive. So what we're experiencing in Canada is the consequences of CDA approval narrowed to the inclusion criteria of clinical trials. Is it the fault of the cost of the drug? Is it the problem lay with CDA's inability to give positive recommendation beyond the narrowed data of rare disease and the need to accommodate provincial funding limitations? Or is the problem with the provinces strictly adhering to the narrow recommendation and refusing to cover urgent cases for fear of setting precedents? Looking at Manitoba specifically today, they have not yet signed their bilateral agreement for the promised federal funds, and they haven't provided us any signs of plans to utilize these funds that are promised to provide treatment for a very serious case. So what I'd like to do is introduce you to Jeremy Bray, who is experiencing this situation in Manitoba. We have fought very hard in Manitoba to get access for Jeremy, who is experiencing progression with his disease and a future that is questionable. So Jeremy, I hand it over to you so you can share your story.
Okay, thank you, Susie, and thank you everyone for having me. Yeah, my name is Jeremy Bray. I'm 29 years old. Born and raised in Manitoba. I worked as an IT and data consultant. For the past few years, I've been working for a school division here in Manitoba. And yeah, I'm here to talk about my experience trying to access treatment for spinal muscular atrophy. I was diagnosed with SMA type 2 when I was about 15 months old. I was never able to walk or even crawl as a baby, and was using a motorized wheelchair by the time I was in kindergarten. Aside from a couple early hospitalizations for respiratory infections and a spinal infusion to correct scoliosis when I was 6, I had a pretty happy and healthy childhood. I went to school, performed well academically, and had plenty of friends. Until recently, the only treatments for SMA were therapeutics, that largely being physio and various respiratory interventions. And I lived well into adulthood, certain that I wouldn't live to see a treatment that could affect the progression of SMA in my lifetime. I grew up knowing my disease would take all my functional ability from me, and there was really nothing I could do about it. I lost the ability to lift my hands to my face and feed myself when I was in high school, and I lost pretty much the total use of my right arm and hand in university. And then it was around this time, not long after I finished university, when news started to come out that there was a drug that could slow or stop, or in some cases, give back some function to patients with SMA. Spinraza was approved in Canada, and people my age in other countries were already seeing benefits. So my family and I knew the funding decisions would take time, but in the meantime, we tried to get a referral to a neurologist. This was the first hurdle because once you turn 18 in many places, your supports essentially drop off to nothing. You're not followed up with the physicians you had, or you're not transferred to new physicians for respiratory monitoring and neurologists. And it took a while to find neurologists willing to take me on. Obviously, SMA is a rare disease, and in Manitoba, with a province with limited resources, there weren't many neurologists willing to take on SMA patients. So, but after a few months, there was one that accepted me in Winnipeg, and in 2018, my family and I drove 3 hours to Winnipeg. We live in a small town. And we were really hopeful and excited that this would be a big change in my life. That hope was crushed almost immediately. The doctor I saw was dismissive, almost callous about the possibility of treatment. He told me Spinraza wouldn't help, that slowing my progression would be impossible to measure, and that the injections, because Spinraza is an intrathecal injection, were too risky. And that my only hope was gene editing therapy that was decades away from being realized. I now know that much of what he told me wasn't backed by science, but at the time, I didn't know anybody. So I pretty much begged him for that when Manitoba finally approved funding for whatever population they would, that he would apply for exceptional access to treatment for me. He did agree, but a few months later, Manitoba announced they would follow the CDA recommendation, which was only funding patients under 18, which I was in my early 20s at this point. When I called my doctor, my neurologist, to see if he would apply for exceptional status, he told me I didn't meet the criteria, and that was the end of it. Around this time, there was word of another treatment coming down the pipe, and an oral treatment called Risdiplam. And so we settled that, okay, we would wait for this one. In the meantime, something pretty big happened, and that the world shut down because of a pandemic, and my family and I quarantined pretty strictly, and treatment took kind of a backseat to survival. But as soon as the COVID vaccine became available, we felt a little safer. I made another appointment with the same neurologist, this time hoping he would apply for an exception for Risdiplam, which was approved for people under the age of 25. But by the time I got in to see him, I had just turned 27. So 2 years past the CDA recommendation that the province was sticking to. When I asked for another exceptional status, he was no more helpful this time around. He said, "Why would Manitoba make an exception for you if they do it for a 27-year-old? What's stopping them from making exceptions for people 28, 29, 30? Where does it end?" But after more emotional pleading, he agreed to apply for exceptional status. It wasn't until many months later that I found out he never formally did so. This was a pretty devastating process. For years, I had fought to access a treatment that was proving life-changing for others with my condition, only to be met with rejection at every turn. I really felt abandoned by the system. So it was around this time we reached out to Susie and Cure SMA Canada, and they managed to connect me with a new neurologist who was more knowledgeable about the efficacy of these treatments and what they could do for adults with SMA and not just children. There was, after all the upsetting experiences, this felt like a big turning point, and in some respects, it has been. But
Jeremy, can I step in for a moment?
Mhm.
We're needing to close up the time for our session, but what I wanted to follow up with Jeremy is that it has been quite the battle within Canada, and I know the other rare disease patients are also experiencing the same thing. It feels like we're fighting, just like Durhan said, inch by inch to get approval for patients in Canada. I feel we pull one more on the life raft at a time instead of getting the generalized approving that the patients deserve. And, we're not done yet, but we're hoping these federal funds will make a difference in the province of Manitoba and that Jeremy's needs will continue. Jeremy's condition is declining, and we are very, very, we need to have access for Jeremy, and not just Jeremy, any patient that is fighting for access for SMA.
Jeremy and Susie, thanks so much for sharing that. It's a real contrast with what we just heard before in terms of what's being built out west. Durhan, do you want to jump in with, because you've jumped on the screen a couple of times with Deb now to maybe talk about what we're going to do to start there? Where do you want to go next, Durhan?
No, I want to go to Deb, and then Deborah, I'm so sorry. I'm going to ask you to really condense it, and we will have a lot more from you in April. So we'll get the fuller story, but I just want to make sure that we do in with where we're going.
Sure, I'll do the short version. Thank you so much, Jeremy, for sharing bravely your difficult story. And actually, I think this sets the scene very well. I'm a health economist based in Calgary. I worked with this CDRN from the very beginning, and very proud to help support that initiative, as well as CORD as part of that initiative in the context of One Child, Every Child. And we all know that individually rare disease is rare, but collectively it's large. So we really need to start thinking about this as a public health concern. Durhan said we're all excited about the rare disease strategy. We're really keen on trying to help people. And the key, I think, now is to think about this from that broad perspective. So the social, the mental, the health challenges facing people living with rare disease. And most of the economic studies that have been done are either in single rare disease or have limited information about what overall impact rare diseases have on people living with rare disease and their families, and actually, even more broadly, society and the overall economy, actually, of Canada because of the impacts. So, what we're trying to do with this survey that's being referred to is bring the evidence and the voices of children and families with rare disease to influence change, from diagnosis to treatment to management, and not just on the treatment, because we need that whole spectrum, that broad view. So we've shown, through work with Care for Rare Resolve, with funding from CHR and Genome Canada, early diagnosis is cost effective, which highlights the importance of access. We've shown the value of diagnosis to families, even if there isn't a known diagnosis or treatment, to make sure they can access the right supports. We are building a value framework to uncover hidden burdens that includes costs, outcomes, and unmet needs. And the CDRN has 3 pillars: the timely diagnosis, access to treatment, and the best practices for families and getting support. So how do we invest that money wisely? And this leads to the survey. We need the data. We need to have the evidence to look at policy-centered solutions that are informed and also can help us guide resource allocation. So the survey, there have been surveys in the US and in Europe, but none. This will be the first ever in Canada nationally to look at the broad range of costs. So direct medical costs, non-medical costs, indirect costs. And by that, I mean, yes, the diagnosis and visits, but also the supports, the physio that one needs, the changes to the house you need to do, productivity costs, not being able to go to work or going to work and not being as productive or engaged as you can be. And we know these are larger, but we need to have the Canadian evidence. So what we're doing is building this survey. It's using standardized instruments that will be scientifically robust, examining the underserved regions. We especially want to make sure we cover all of Canada and not just the most populous areas, looking at the health care quality of life of patients and caregivers, as well as the productivity aspect. So how does this impact career opportunities, lost work, education? So we will have a shorter version because we realize that, it takes more of your time, and we know that families are already very busy with many other things, but we'll make a short version, hoping we can get a core large set, as well as a longer version where it will go into deeper dive to get more details on this. And I plead to you, as Bill suggested from the beginning, we really would appreciate your support in trying to do this so that we can collectively use the results from this to make these informed policy arguments to make some of the changes we're hoping to do across that whole trajectory, not just in the treatment side. So
Thanks,
thank you
Deb.
very much.
Really appreciate it. It looks like you coordinated outfits with Durhan too, which is how did that happen?
I can only aspire to be like Doreen.
There you go. You know what? We've actually, there's been amazing engagement online, and I've got even some direct questions from somebody on Prince Edward Island saying, hey, how do we get the island to sign that? Because we're now down to just 2 provinces, both in Atlantic, who haven't signed their bilats. So I'll get back in touch with you about that. But Durhan, I know we're going to close at 1. We were hoping to leave time for discussion, but do you want to help close it out in terms of your reaction and where we go next?
Well, I am pleading with all our panelists to come back for our conference in April, where we will have more time. Always my problem is I have way too much I put on the agenda, only because there's so much that's going on. And I think everybody here will be inspired by what is going on in Canada, or as Jeremy and Susie has indicated, what it is that we're not doing despite all the resources that we have. We need everybody to work collectively. As Bill says, we launched the rare disease strategy back in 2015. I will say, Bill, I looked at our initial slides and I say we have made huge progress since then, but it's really been not from the government. it's really been from the community. Everybody from the researchers, the clinicians, the patient community, all the way through. We have driven rare diseases in Canada to the kind of state of art that you hear from Kim and Miriam and Deborah. So we can do it. We will have to do it, but at least now the provinces have some money that we can have them use for, and we will also be able to hopefully invite other investors to come in. So stay tuned. Please do join us in April in person if you can, and we will hopefully have a couple more webinars. One this spring and certainly after our April conference as well. So thanks everybody for coming. Always my huge thanks to Bill for hosting and the masterful walkthrough. Could not thank everybody enough, and for all the comments as well. We will capture those. If you have additional comments or stories, please do send them to us. We will want to capture everything, and we will try to work together. There are some great suggestions in the comments that we want to follow up on, everything from emergency access programs to how we can encourage research and I think everybody wants Tom at your center. So, get building on that one, and then you can loan yourself out as a carpenter across the provinces. I'm sure that you will be much welcome.
Thanks, Darhan. Thanks, everybody. Take care. We'll see you in Calgary, but probably earlier with those webinars. So let's keep the conversation going. And happy Rare Disease Day. Hope you get to celebrate wherever you are. Every day we are going to make Canada a better place for rare. So thanks very much.